We move to our next session. Moderators for the next session will be Dr. Tanmay, Dr. Tarun Bansal, Dr. Riyaz Charania. Chairpersons are Dr. Vikramaditya, Dr. Gajendra Dubey, and Dr. Rupesh Singhal. I request the chair to invite these speakers, introduce them, and introduce the topic. Over to chair. Dr. Gajendra, Dr. Rupesh, Dr. Tanmay, Dr. Tarun Bansal, Dr.
Hello.
Riyaz.
Good afternoon.
Please unmute yourself. Yeah. Yeah, Dr. Vikramaditya, you go ahead. Please introduce the topic and the speakers.
Sir,
Yes, you're audible and visible. Please go ahead.
Good morning, everyone. And this is a 55-year-old female who presented with NSTEMI, and she was found to have triple vessel disease and with a reasonable LV function, which is 45%. And patient had a history of left-sided TIA, 2 episodes, 12 months back. And on preoperative workup, she was found to have a 95% stenosis in the right internal carotid artery with mild disease in the left side. So now what would be the preferred sequence of revascularization? We'll hear from the speakers. I welcome Professor Chirag Doshi to initiate this discussion.
Yeah, very good morning.
He is a professor at UN Mehta Institute, and he will start the discussion.
Hello. Hello.
Yes, Chirag, you are visible and audible. Please
Yeah,
share your slides.
am I audible?
Yes, please share your slides. Yeah, please go ahead.
Let me give me a time. Just a minute.
Sir, we are able to see your presentation. You can go ahead.
Oh, you're able to see my presentation?
Yes, sir.
Yes,
Yes,
we
sir.
are able to see. You can just scroll the slides. You can make the full screen. That's all.
Just a
click
minute.
on the right lower end, the full screen, and then we'll be.
Give me a moment. I'm unable to do it from my side. Just bear with me for a few seconds more.
Yes, perfect. Go ahead.
Yeah, first of all, good afternoon, all the dignitaries and delegates. And before even I start my presentation, I must congratulate Dr. Kamal Sharma and his entire team for putting up this wonderful academic event in this very difficult and tough time. And I really want to thank them for having me on this online symposium. So yes, a case which was given to me is middle-aged lady presented with non-ST elevation MI on angiogram revealed a triple vessel disease with 95% stenosis in the left carotid artery with very mild involvement in the left system. So obviously my preferred sequence of revascularization would be a right carotid revascularization followed with CABG in a synchronous or in a single stage. So before I go ahead, I would like to give you a very basic insight as what I'm going to discuss in fact in next few minutes. So let us understand what is carotid artery stenosis and its correlation with coronary artery disease, in which group of patients to treat and why, what is the right time to intervene or when to do a carotid endartrectomy, and how to do carotid endartrectomy safely with off-pump CABG. Again, this is more of a surgical interest. So coming to the main talk of the day, the North American Symptomatic Carotid Artery trial, they have classified carotid artery stenosis on the base of degree. They have classified into 4 categories, starting from less than 50% to total occlusion. And it is further classified into the symptomatic groups, if the symptoms, if associated with symptoms in preceding 6 months of presentation of MI, they call it as a symptomatic group. And if it is preceding more than 6 months of time, they call it as an asymptomatic group. So we all know that there is a strong existence of carotid artery disease with hello, am I audible there? Hello.
You're perfectly
you are
audible.
audible.
You're going great.
Okay,
Keep going.
okay. There is, as I was mentioning, that there is a strong existence between coronary artery disease and carotid artery involvement. It can range right from 5% if the one coronary artery is involved. It can go up to 40% in patients with left main coronary artery stenosis, or else with a severe triple vessel disease. So there is no doubt about their coexistence. But as per the systemic review by Naylor et al., if you leave alone carotid artery disease at the time of CABG, the perioperative stroke rate can be ranged from 2% to 11%, and that all depends on the degree of stenosis, as well as the whether the carotid artery involvement is in the one side or a bilateral side. So this is again a very important thing to understand, that we need to intervene a carotid artery at the time of CABG to reduce the further risk of stroke. So when to do a CEA, whether it should be done together or synchronous fashion, or CEA first followed by CABG, or CABG first and followed by CA, vice versa. So now we have to answer all these questions and queries. Now we have enough supporting evidences from across the globe in the form of guidelines, presentation, and publications. So let me tell you this thing. This is not really a new approach. This has been there in the world for last more than 4 decades. They combine carotid artery procedures with CABG. The only difference now and then, now the most of the CABGs, especially in country like India, has been done on off pump, that we do not use a cardiopulmonary bypass. And but during those time, the off pump procedures were not available. So most of the surgeries were performed on pump with carotid endartrectomy. So what is the goal? Why we need to intervene carotid artery disease at the time of CABGs? So the goal, primary, whatever you do, whether you do a carotid artery stenting or carotid endartrectomy, the ultimate goal is to reduce the stroke rate. So there are 2 trials that has been, widely accepted by the world. That is a North American symptomatic carotid artery endartrectomy trial and asymptomatic carotid atherosclerotic study. Both of them have demonstrated that the simultaneous or synchronized carotid endartrectomy with CABG significantly reduce the risk of stroke, perioperative stroke, than when it is done alone. So this is again, I have taken this slide from Current Opinion in Cardiology 2011, where if you look at this slide very carefully, so if the patient is symptomatic, like in our case scenario, patient is asymptomatic, but because patient has symptoms almost 12 months prior to the her presentation of non-STEMI, so our patient falls in the category of asymptomatic group, but the degree of stenosis is 95, so it will fall into asymptomatic 80 to 99% carotid stenosis. Obviously, patient is presented with ACA, so patients who fall into this category, their preferred choice of treatment would be the synchronized CEA with CABG. So here you can easily identify that this patient definitely would require a combined procedure, and that is the first choice of treatment would be a CEA with CABG. And then there are other evidences, and there are guidelines. There are guidelines from AHA and ACS. What they say is this was again published in 2014. Till for 2014, we did not have a right guideline whether we should do it CEA first and then CABG, or CABG followed by CEA or CAS. So what this guidelines tells us, that if patient is symptomatic, that means that if patient has developed symptoms within the 6 months of their myocardial infarction presentations, obviously they need to undergo a CEA and CABG together, and they have the very high stroke, very less percentage of stroke, as well as TIA, at the time of in perioperative time. So this was further supported even by European guidelines. See, till 2017, we did not have again a very classical guidelines for asymptomatic group. Now, at least in European guidelines, with the help of vascular societies, what they've come up with, that it is now, even if the patient is asymptomatic, but the degree of stenosis is more than 70% to 99%, so that is how they included in class 2B. So now we know that this type of patients definitely would require a surgical or stenting intervention. Which one is better? So what they said is, if it is being done together, the perioperative stroke rate, perioperative MI risk is way less, at least half of than when it has been done individually. So what are the indications of for carotid endartrectomy by and large? So we have now recent evidence-based guidelines published by Society for Vascular Surgery, and what they've recommended is, in an asymptomatic group of patients, if the stenosis is between 60 to 90%, if perioperative stroke rate and the death rate is less than 3%. I'm sorry, just give me a few more seconds before I conclude. Yeah, sure. Thank you so much. So like in our case scenario, our case is like a low risk patients for CABG. Death rate is definitely less than 3%. The first treatment of choice would be a CA with CABG. Right. So there are numbers of papers who are supporting that, yes, this case should be done together. And now the question is whether CAS and CABG together or CA and CABG together. So my preference would be a CA single stage carotid and surgical endarterectomy with CABG. Definitely will reduce the risk of perioperative MI, perioperative stroke, and definitely being in a developing country, if we add two procedures, the financial burden will be more. So to reduce even financial burden, this is the way to go about it. So there are a lot more papers across the globe, across the world. This is our own paper from India. It's published in Academy of Neurology, where they say the combining CE and CABG is a very safe and effective procedure. Like this is again a very landmark paper from Illuminati. They also say the CABG with CAE again prevent a stroke rate, and overall surgical risk would be way less. And now with the recent onset, we do, as I said earlier, we do more and more of off-pump CABG. So if it can be done with off-pump CABG, that will further reduce the risk of perioperative stroke and perioperative MI and mortality. So what are the demerits of carotid artery stenting? If carotid artery stenting is done prior to the surgery, there is definitely a risk of kidney injury, and patient may not be suitable to take a dual antiplatelet at the time of surgery. And if we do a carotid artery stenting, there is a high risk of stroke and MI prior to a surgery. So there are definitely a few merits which tells us that yes, these procedures can be done synchronously, which will reduce perioperative stroke, decrease the morbidity associated with additional procedures and anesthesia. Financial implications is, again, as I said, it's a big burden for Indian society. And this procedure should be best reserved for patients with significant carotid artery disease. So I will not discuss, because as we are running short of time, I will not go into the detail of surgical steps. Okay, but only things that I would like to add on this, these are the few stents which are available to maintain the integrated cerebral perfusion during the procedure when the clamp is on the carotid and common carotid and internal carotid artery, right? And this is very small. If you permit me, there is a small video of it, but I will again skip this because we are running short of time. So in my institute where I practice, we have a large volume centers, and we do quite oftenly carotid endarterectomy with CABGs. So if the CABG is a really high risk, what we do is we do not induce patients till we perform carotid endarterectomy. So actually patient is awake. We give a regional anesthesia at the time of procedures, and we can actually assess neurology at every point of procedures. So that is how we can reduce the further stroke of incidents during this procedures. So to conclude my talk, take-home message: a combined CE and CABG is preferred for patients with significant carotid artery disease and severe triple vessel and left main coronary artery disease with lowest perioperative and post-operative stroke rate and myocardial infarctions. Again, thank you, Kamal, for having me here and allowed me to speak about a surgical approach to deal with carotid artery disease. Thank you.
Thank you, Chirag. It was our pleasure. Over to Chair.
So,
Dr. Gajendra, please introduce Dr. Joshi. Yeah.
yes, so now I would like to invite Professor Hasit Joshi, an eminent cardiologist at UN Mehta Institute and Apollo Hospital, for his views on whether CE is better or carotid artery stenting is the way to go before CABG. Dr. Hasit, sir, please.
Thank you, Kamal and CARDIOCON, for inviting me. So our case, I am audible? Hello?
Yes, sir.
Yes, you are audible and your slides are visible. Please go ahead, Hasit bhai.
So our case is female, 55 years, who had a recent ACS, mild LV dysfunction, history of TIA before 12 months twice. So probably we can consider as asymptomatic, though guidelines suggest that 6 months is the thing. And pre-op, a very tight stenosis, 95% stenosis of the right ICA. So what are the issues? Whether CABG is required, carotid intervention is required, what are the risks, stroke, MI, death and bleeding? What is the preferred mode of revascularization, surgery versus stenting, and the sequence of the revascularization and the pharmacotherapy. So we'll go step by step. And because patient has ACS, a triple vessel disease, medical management has poor survival of about 67 to 73% at 5 years. And there are lots of trials which has suggested that CABG would be better. So there is no question about that revascularization in form of CABG would be required. However, a CABG entails many cerebral complications, and silent brain injury is detected in about 25 to 50%. Incidence of major stroke is about 1.5 to 5%. And this is irrespective of carotid artery stenosis. There are lots of sour emboli which are occurring during CABG. Off pump would probably reduce it, but still there is a risk of cerebral complications during CABG. Now, patient has symptomatic carotid artery stenosis, right? So what is the natural history of carotid artery stenosis apart from the coronary artery disease? Cumulative risk of stroke is about 30 to 50% at 5 years. And 1/3 of the patient die usually of CAD. And stroke risk is 10 to 30% in first year, 6% in subsequent years. Now, when carotid artery stenosis is concomitant with coronary artery disease, risk of stroke for 3 months post CABG in patients with ICA more than 70% is 70%. And presence of carotid artery stenosis in patients with triple vessel CAD is suggestive of diffuse atherosclerosis. So patient falls at high risk of complications, either cardiac or neurological. Now, what are ACC/AHA guidelines? Now, this is for carotid artery stenosis, more than 70%. Symptomatic patient, more than 70% should undergo revascularization, either in form of CEA or carotid stenting. And the anticipated rate of perioperative stroke or mortality should be less than 6% for the procedure to be acceptable. This is summary of recommendation. Symptomatic patients, 70 to 99%. Endartrectomy versus stenting, both are class 1 indications. And for asymptomatic patients, 2A and 2B. Now, these guidelines are 2011. Unfortunately, no other guidelines have come up after that. Only just a correction came in 2014. So carotid artery stenting is indicated as an alternative to CEA for symptomatic patients at average or low risk of complications associated with endovascular intervention. And anticipated rate of periprocedural stroke and mortality should be less than 6%. Now, when we consider carotid artery stenosis with CABG, neurological risk reduction in patients with carotid artery disease undergoing cardiac and non-cardiac surgery, Carotid revascularization by CEA or CAS, carotid artery, with embolic protection before or concurrent with myocardial revascularization surgery is reasonable in patients with greater than 80% carotid stenosis. So here it is very clear that carotid has a preference, and hence carotid intervention should be before or with CABG. Now, what are the factors associated with increased risk from carotid artery surgery? And in this, if we see at the medical comorbidities, class 3 or 4 angina pectoris, 2 or 3 vessel disease, need for open heart surgery. These are the 3 ticks in which our patient follows. For factors associated with increased risk complication with carotid artery stent placement, if patient has a tortuous aortic arch, platelet or clotting disorders, difficult vascular access, lesion or vessel calcification, visible thrombus or advanced age. Here we do not have data, but if we can rule out this, probably patient is at a low risk for carotid artery stent placement. Now, what are the problems with CEA and during CABG? Cardiovascular instability when CEA is done is reported in 20% of patients undergoing carotid endartrectomy. Hypertension in 20% and hypotension in 5% and perioperative MI in 1%. Wellmar reported in stroke 2017 that CABG plus CEA had nearly double the rate of stroke death within 1 year compared to CABG only. And this is 2020 article in Annals of Vascular Surgery. CABG with CEA versus staged carotid stenting versus CABG. They did a systemic review of 5 studies, 16,712 patients. Stroke MI similar between 2 groups. However, CEA, CABG were at a higher risk of operative, perioperative mortality. Odds ratio was 1.8. Now we go back to 2002 study Sapphire. In this patient, because of this is a higher risk for CEA. So Sapphire study, all patients who are at high risk for CEA, randomize them to stenting with protection versus carotid endarterectomy, and primary endpoints at 30-day death, stroke or MI. The inclusion criteria: patients with open heart surgery within 6 months, 6 weeks, sorry, recent MI or unstable angina, and these are the 2 in which our patient takes. The trial was discontinued early due to low enrollment. However, despite the lower than expected enrollment, the rate of 30-day composite primary endpoint was lower in the stent arm versus the CE arm, 5.8 versus 12.6. And when this trial was seen up to 1 year, still the stenting group had a lower incidence of event at 20 versus 12%. There were 2 other trials, CREST and ICSS, which were carried out after this, and this were comparing CAS versus CEA and found similar rate of morbidity and mortality, death, MI or stroke. This was not in CABG. Now, this is a national sample study of 27,084 patients who underwent CAS before CABG or combined CEA plus CABG between 2000 and 2004. This is a very old study. At that time, CEA was the preferred mode and CAS was just developing. However, what they reported, sorry.
Sir, time is up.
Yeah. Now with filters, the stroke rate decreased from 8 to 2.4% in Sapphire, in Acunate 4.9 to 3.6. CS over the years have progressed from 8% 30-day death, stroke and MI rate to less than 2%, less than 3% in this. And experience matters. There were 2 trials, SPACE and EVA 3S, where operator should have performed 25 procedures, not necessarily carotids. These were negative trials for carotid artery stenting. Our team is doing more than, in the past 6 years, have done more than 300, and the stroke rate is less than 2%. This is one trial which meta-analysis going on, which will consider all the 6 strategies, that is CEA prior, with or post stenting, prior, with or post CABG. And this meta-analysis will be published. This is 2020 Annals of Translational Medicine, will be published later on. Thank you.
Excellent talk by both the speakers. Over to chair. Dr. Vikramaditya, Dr. Gajendra, Dr. Rupesh, Dr. Tanmay, Dr. Tarun, Dr. Riaz. We are open to discussion, please.
Thank you, sir. It was a really interesting case and brilliantly chosen case by Dr. Kamal Sharma, because otherwise young and say healthy patient with reasonable LV function, but with say some high risk features indicating that the person can be benefited from CE. And earlier, we all know that carotid endartrectomy was the gold standard for such interventions. And armed with CREST and Sapphire, we can say that CAS is as good. So, but in this case, the experience also matters, and because UNM being a high volume center, and both procedures can be done simultaneously. And now, since we are doing more off-pump cases, so the risk of stroke is also minimized.
So it was a wonderful presentation by both the speakers, and I think the case is very interesting. The data on this particular subset is lacking. Patients who are undergoing CABG and who have carotid artery disease. So according to me, the anatomy should also dictate, as Dr. Hasit pointed out.
Yeah.
That anatomical factors are unfavorable. Endartrectomy, then the other procedures should be chosen. And another important thing which I want to emphasize is this patient is theoretically asymptomatic. So whether he should undergo carotid intervention or not, that is also a subject which can be debated upon. Rupesh?
Yeah, thank you, sir. Wonderful talk. And actually, what Dr. Gajendra said, same. I just wanted, in asymptomatic disease, like what do we really know the kind of benefit or harm that we are doing? So that was one thing. And just to, just for the sake of discussion, do we find like in a hybrid, in a combined approach with doing carotid surgery with CABG, is there some difference if a dedicated surgeon attempts this, and what's the take of the speakers on this?
Interesting points, both of you. My point is that how long in the history would you consider it as asymptomatic? This patient had a TIA 12 months back. So I would not categorize this as asymptomatic, or will you still consider it asymptomatic for the time being? And he already has a 95% culprit lesion, which has given symptoms. Yes, Dr. Hasit Bhai and Dr. Chirag Bhai.
Yeah, that is what I emphasized in my talk initially, that though guidelines say that patient beyond 6 months are considered asymptomatic. If you see at natural history, right, the stroke rate in the first year is about 30%, 13 to 30%. Even after that, every year there is a stroke rate of 6%. And those patients undergoing CABG, if he has a tight lesion of more than 70%, in the next 5 years, the stroke rate is about 70%. So for all practical purposes, we should consider that this patient is symptomatic. And if you can give an intervention which decreases the stroke rate less than 6%, you should intervene. With newer guidelines for asymptomatic patients, the stroke rate should be less than 3%, right? If you are doing carotid intervention in a asymptomatic patient, your event rate should be less than 3%. Now, unfortunately, after 2011, no guidelines have evolved. In our institute only, we have more than 300 patients in last 5 years. Stroke rate is less than 2% with 100% use of EPD. So EPD is a game changer. With the EPD, if your institute shows a stroke rate of less than 2% or less than 3%, this intervention should be done. And
Sir,
steering has been stopped.
Dr. Chirag, will you be comfortable not touching the carotid in this case? Dr. Chirag Doshi?
Yeah, it's a very valid question that has been raised. If it is only carotid artery involvement and had it been not a TVD, okay, I would still consider these patients on medical line of management, because patient had a history of TIA 12 months back, and for almost 12 months, patient has become absolutely asymptomatic whatsoever, right? Whatever may be the reason. But if I'm going for a surgery, because surgery again, doing whether it can be done on pump or off pump, will carry some kind of a risk of stroke itself alone. Having 95% stenosis in carotid artery will further increase the risk of stroke. Why? Because one of the reasons that during surgery, there will be a lot more hemodynamic changes. There may be a episode of hypotension. That patient may not tolerate well with the 95% stenosis. If we, in fact, most of the time, when we have a disease in carotid artery, we do an untouched aortic technique surgery. That means we do not touch aorta at all, right? We do try and do more and more of on off pump lima rima or lima radial, something like configurations composite graft. So that is how one can reduce the further risk of stroke. But having said that, if the anatomy is unsuitable, then I would definitely consider these patients for carotid endartrectomy with CABG. There is no doubt about it. If I have to perform CABG, I would definitely consider this patient for carotid intervention as well. So now the question here comes is whether we should do it surgically or with stenting.
Okay.
So can be done hybrid approach where cardiologist can intervene in the morning and then surgeon can take up this patient immediately after stenting, right? So these approach also can be definitely can further reduce the risk of procedure MI and stroke both.
To the chair, because Dr. Gajendra and Dr. Rupesh raised the point. When would you be comfortable calling it asymptomatic? How old the TIA? 4 weeks, 4 months, 4 years? When would you say, no, now I don't want to touch it?
The guidelines mention 6 months as the cutoff for calling it as symptomatic. And regarding updated guidelines in 2017, ESC released a statement type of thing on peripheral arterial disease, which included carotid also. So they have emphasized that there is not much data on touching asymptomatic carotids. Asymptomatic defined on TIA within 6 months is they have considered it as symptom and some other plaque. Say there is thrombus, high plaque burden, or contralateral carotid disease, or some silent infarcts, then they can be considered, but it has not been recommended as a class 1 indication.
Absolutely.
And in my institution,
I deliberately put it that as 12 months back to create a debate. So if I was to put it the recent TV, there was no debate.
Then it would have become a straightforward thing. So at our institute also, many neurologists even they dissuade us from going for routine carotid stenting or endartrectomy before sending them to CABG. Chirag sir also must be aware. So I think if we have any neurologist in the panel, he can also throw
let me say one thing.
Some light. That we have got a few patients operated with severe carotid disease.
Let me say one thing, that these guidelines are based upon many old studies where the event rate was more than 6%, hence symptomatic. But if you create a registry of your own institute, and if your stroke rate is less than 3% with EPDs, probably carotid stenting is the preferred thing.
So I think probably we need more data. So we should conduct a study kind of thing. That will be great.
I cannot share my screen, but probably we have done more than 300 carotid stentings in the past 6 years, and our stroke rate is less than 2%.
Yes, sir.
Sir, I would like to ask, what is the experience on hybrid approach, coronary stent, carotid stenting followed by CABG in the same sitting in this kind of case with ACS and TIA?
Can I share my screen?
Sir, time is up.
Okay.